Hello everyone, my name is Goran Šimić. I am professor of neuroscience at the Croatian Institute for Brain Research. The title of my presentation is ALZENTIA, a sensitive non-invasive hidden goal test for early cognitive impairment screening. The background of our efforts lie in great interest in finding good predictors of mild cognitive impairment or minor neurocognitive disorder, as it is called in DSM-5. The mild cognitive impairment condition usually progresses to Alzheimer's disease, so it is important to find those cases as early as possible. For this purpose, the mini-mental state examination is the best known and the most often used short screening tool. However, mini-mental state examination test is not a mental status examination. It has been designed to detect, to differentiate organic from functional psychiatric patients. Therefore, it comes as no surprise that MMSE has low sensitivity, has poor specificity, and also low negative and positive predictive values. Therefore, it also came as no surprise that a systematic meta-analysis of many studies revealed that mini-mental state examination cannot stand alone as a single administration test in the identification of MCI patients who could develop dementia. Then it is the fact that mini-mental state examination, 30 points at the test, are scored on the basis of neocortical processing. But non-cognitive behavioral and psychological symptoms of dementia are often not considered by mini-mental. So old clinicians already in 90s noticed that these behavioral and psychological symptoms of dementia usually precede the cognitive changes. These symptoms include depressive symptoms, mood change, social withdrawal, confusion, agitation, disturbed wake-sleep cycle, and many others. And these symptoms on average appear, and that has been revealed by retrospective studies, on average 33 months before the diagnosis of Alzheimer's disease. So clinical pathological correlations confirm this fact that early pathological changes in Alzheimer's disease occur in the brainstem, particularly in the locus coeruleus and dorsal raphe nucleus. At least 6 to 8% of the cases, respectively, start in these two brainstem nuclei, and the rest of the cases usually occur coincidentally in the brainstem and transentorhinal region. This can be confirmed by neuropathological studies. On the left side, you can see locus coeruleus, neuron loss in Alzheimer's disease in comparison to control brain. And on the right side, you can see the neurofibrillary changes in an early MCI case in dorsal raphe nucleus. Finally, the premise of our work is based on the fact that hippocampal formation is specialized for orientation in space, and this has been made, and Professor Richard Morris in 1982 made a Morris-Watermays task, an experimental paradigm to reveal early changes or experimental changes in the hippocampal formation. So we were looking for a human analog of this capability to orientate in space, but without using water. As you can see that in Morris-Watermays task, you have a hidden platform in the water, which animal depending on the intactness and functional capacity of its hippocampi, is able or not able to find. So Our work is based on original efforts of Professor Jan Bureš from Prague, who was the first to make a so-called hidden goal test or hidden goal task, where we improved, we made our original software and hardware to make an arena in which a circle is presented by a laser randomly on the floor, and the task of patient is, after it disappears, to find with a stick the original position of this stimulus as precisely as she or he can. So it is based on egocentric on the left side, where there are no orientational landmarks, only the starting point, or it could be the allocentric version of the test, where 8 different orientation landmarks are hanging on the walls of this tent-like structure, which is arena, a space where testing is being performed. In the meantime, since the registration for the conference, our preliminary results have been published in Journal of Neuroscience Methods. So we included 91 healthy control and 33 mild cognitive impairment cases. Initially, we started to devise an instrument for recognition of Alzheimer's disease. However, out of first 8 patients, only 1 succeeded to get to the end of the test. So the test is simply so sensitive that we have focused on differentiating healthy controls from mild cognitive impairment cases. Results include average errors during the first 4 attempts or all 8 attempts, and combined results of allocentric and egocentric testing. But the error measured in egocentric subtest, the average of all 8 attempts, showed overall the best discriminative properties. So the area under curve had the greatest discriminative potential to differentiate between cognitively healthy controls and mildly cognitively impaired cases. So overall diagnostic performance was 93.9% for sensitivity and 76.1% specificity, which means that the test has very high negative predictive value, which was generally over 90% in all subtests and all prevalences. We had to check for different prevalences because annual conversion from normal cognitive performance to mild cognitive impairment varies from study to study. So high negative predictive values can be, we can conclude that high negative predictive values means that the test can be used for screening purposes. So relatively lower positive predictive values means that generally the test should not be used as a single confirmatory test for making diagnosis. So generally the results of negative predictive values were much better of this test than the results of positive predictive values. High negative predictive values is the main feature of a test that could be used for screening. Relatively lower positive predictive values does not mean that it should not be used, but only that it should not be used as a single confirmatory test. So I will provide you with one example. So if this particular egocentric subtest, if it has at prevalence set at 36.7%, it has 69.5 positive predicted value and 95.6 negative predicted value. This means that the rest, or 30.5% probability, is that no MCI exists with a positive test, and only 4.4% probability of MCI with negative test. This means if a person is negative on this test, then we are pretty sure that she or he does not have a mild cognitive impairment. So that's the main conclusion, that it is quite usable and has great potential to be used as a screening test. However, it can be also used as a good confirmatory test, perhaps in a subgroup of all MCI patients, or when patient shows some additional indices of dementia, such as worsened performance or having some plasma or CSF biomarker positive. Yeah, I will conclude with this and invite you to the Mediterranean Neuroscience Society conference in Dubrovnik next year. During the conference, we will present new results using the ALZENTIA system. Thank you.